Welcome to our sonography lecture on renal pathology, part 1 of 14, renal anomalies for the sonographer. This lecture will cover renal agenesis, renal hypoplasia, bifid renal pelvis, renal ectopia, crossed renal ectopia, cake kidney, and horseshoe kidney. We've learned in previous anatomy lectures about congenital variants, and we know that the variants just kind of change how the kidney looks a little bit, but doesn't really affect the function or location of the anatomy. With renal anomalies, we're really going to focus on, again, congenital abnormalities, but now they really are going to alter the appearance, location, and maybe even the function of the kidney. Let's go ahead and get started then with renal agenesis. Just breaking down the word, we know that A means without, genesis, formation of. So renal agenesis means that one or both of the kidneys fail to develop. Now this is really thought to be part of the development in utero, and that maybe something happened that made those kidneys not develop. And in particular, we're looking at like a vascular accident. So maybe the renal artery got occluded on one or both sides, therefore no blood was getting to the organ as it was developing, and therefore it doesn't end up developing. Now bilateral agenesis, that means both kidneys are missing, is going to result in uterine demise. Remember that the kidneys in utero are responsible for aiding in the creation of amniotic fluid. If there's not enough amniotic fluid, then there's a lot of pressure on the fetus's chest, therefore the lungs cannot develop, and it just is kind of a cascade that leads to fetal demise. Now in ultrasound, if this is a unilateral abnormality, the adult patient or pediatric patient that we have on our table will have an empty renal fossa. So one of the fossas will not have a kidney in it. What ends up happening then is, because there is still one kidney that's functioning, that kidney becomes what we say compensatory hypertrophic. And that means that it's going to get quite a bit bigger because it's doing the work of two kidneys. Another thing we might see is called the lying down adrenal sign. We know that the adrenal glands sit right on top of the kidneys and they kind of bunch up into this like little triangular shape. But when that kidney's not there to kind of hold it in place, it can fall out and elongate a little bit more. So that's what we call the lying down adrenal sign. Now, if we're scanning a fetus and are looking for both of the kidneys, as we should during our fetal survey, we might notice again that one side is missing the kidney, or we might see that both sides are missing the kidney. So we would not see any renal parenchyma in the expected area or even down in the pelvis. We also can check the aorta to see if we can see renal arteries coming off of it, and then the fetus will have oligohydramnios or low amniotic fluid levels. So here we have a patient that has an empty right renal fossa, and we have the lying down adrenal gland sign here. So here's the adrenal gland. Normally they're kind of bunched up in a little triangle. We can see it elongated out, and then we don't see any renal tissue in the area. Now we're going to learn a little bit that sometimes kidneys can take off and head to other places. We do want to make sure as a sonographer that we are checking those other places that the kidneys like to migrate to before we call it agenesis. And chances are this patient's going to need a CT to confirm agenesis. But when we find a missing kidney and we don't see it anywhere else, it most likely is going to be renal agenesis. Here's an example of an in utero exam. We would expect the kidneys to lie on either side of the aorta, and what we're seeing here is an aorta lacking any renal arteries extending off of it. Normally we would see them coming off the lateral sides of the aorta. So this is another way that we can show that renal agenesis has occurred. We can see too there's no amniotic fluid around this fetus, and this will most likely end in demise. Our next anomaly then is renal hypoplasia. Again, breaking down the word, hypo means smaller, plasia means, building of, so small building or small kidneys. So when we have renal hypoplasia, the true definition of renal hypoplasia is that it is going to contain 5 calyces or less. Our normal kidneys are going to contain upwards around like 13 calyces. So we're just going to have a small, petite kidney. The kidney still functions completely as it should, as we would expect, But we want to make sure that we're not confusing a small normal kidney with renal hypoplasia to a kidney that has been affected by disease, like with renal artery stenosis or cystic diseases. So renal atrophy is not the same as renal hypoplasia. Renal hypoplasia just means the kidney was built a little bit smaller, less calluses, functions completely normal. Renal atrophy, as we're going to learn, means the kidney is smaller, but it's due to a disease. It was once normal and then shrunk. On ultrasound then, renal hypoplasia is going to look like a small kidney. It's going to look exactly like we would expect, just smaller. And we consider the hypoplasia portion of it as we compare it to the other kidney. So in adults, we want our kidney sizes to be within 2 centimeters of one another. So if we have a difference of, say, 7 centimeters on the right side and 10 centimeters on the left, then we might start to lean towards that hypoplastic right kidney. Pediatrics, however, we want those kidneys to be much closer in size. We expect them to be within 1 centimeter of another. So here's an example on ultrasound then. We have a very tiny right kidney here, and we actually have a very normal sized looking left kidney. Again, the right kidney is just small. It looks completely normal. It's just on the smaller side. Bifid renal pelvis is probably going to be one of the most common things that you're going to see as a sonographer. And what it means is that one kidney has 2 collection systems. Now, when we learned about anatomy, we know that the minor calluses dump into the major calluses kind of dump into the sinus, which goes into the ureter, and all of the urine exits out one ureter. Bifid renal pelvis changes that setup a little bit. So what happens in bifid renal pelvises is that we actually have 2 pelvises. So we have some calluses dumping into one pelvis, and then we have another set of calluses dumping into a second pelvis. Typically 2 ureters come off, and what happens with those ureters after they come off changes the variant. So a complete bifid renal pelvis means that there's 2 pelvises, 2 ureters, and then 2 insertions into the bladder on the same side. So if you have a duplicated or a bifid renal pelvis on the right, you're going to have 2 ureters inserting on the right side of the bladder. Incomplete bifid renal pelvis, which happens to be the most common, means that there's 2 pelvises, 2 ureters, but only 1 insertion into the bladder. That second ureter usually inserts somewhere into the other ureter before they insert into the bladder. Now, bifid renal pelvis is a really important one to know because there are complications that come along with it, and it has a very distinct ultrasound appearance. The complications that we see with bifid renal pelvis is that the upper pole is more likely to exhibit pathology. And the pathology that we usually see on that upper pole is called hydronephrosis. And hydronephrosis means that there's urine kind of backed up into the collecting system, and we can see that then by ultrasound. And we think that this upper pole is more likely to have pathology because of the way that that superior pole ureter inserts into the inferior pole ureter. It just causes a lot of extra pressure, and that upper pole doesn't drain as well. The other thing that we see too in a complete bifid renal pelvis, that superior pole ureter tends to have more complications at its insertion site into the bladder. It either inserts really high or has a ureter seal, which means it has like this little bubble at the end, which just doesn't allow that upper pole to drain as well as the lower pole. So here is a diagram of the bifid renal pelvis. Again, we have a superior pole pelvis and an inferior pole pelvis. Now, in ultrasound, they actually do have a pretty distinct appearance to them. The kidneys tend to be just a little bit larger, and we say that they're faceless kidneys. And what we mean by that is that it's a little bit harder to get a transmid kidney. If I go back to our diagram here, think about it. We usually have one sinus right through the middle here. We kind of get that hilum break. What we end up having is kind of this weird hilum up here, a weird hilum down here. We've got renal arteries going in both. And so it's just hard to get that true C shape that we get with our normal kidneys. We're also going to see that there's a prominent column of renal cortex that kind of cuts through the middle of the kidney. So that's that very clear, distinct sign of a bifid kidney. Again, we're going to commonly see hydronephrosis in that upper pole. We might see a ureter seal in the bladder. And then if it is a complete bifid renal pelvis, then we should be able to see 2 ural jets coming from one side. So here's an example of a renal bifid pelvis. We've got a kidney that looks just a little bit larger. And what's really prominent on these renal bifid pelvises is that we have this prominent column of cortex that cuts through the middle. So here's one upper pole collecting system, and then we have the lower pole collecting system divided by that renal cortex. Here's another example then of bifid renal pelvis, or a duplicated system. We've got the kidney here, lower pole collecting system, upper pole collecting system, and a prominent column of cortex in between. This is where that faceless kidney comes in. Unfortunately, we just can't really see that hilum break like we normally do, so we end up getting a full cortex around, especially if we're kind of measuring right through this area here. Here's an example of hydronephrosis in the upper pole. So again, we have that prominent column of cortex dividing the two halves, dividing the two collecting systems, and that upper pole is most likely going to have fluid within it. A ureter seal, which we will learn towards the end of this lecture series, is an outpouching of the ureter into the bladder, which actually makes it difficult for urine to exit appropriately. So the superior ureter, if it is a complete bifid system, is commonly going to show a ureter seal at the end of it. Next up, we have renal ectopia. So renal ectopia is kind of this overarching idea that the kidney has not made it to its expected position. In utero, we expect that the kidneys, which are developing in the pelvis, are going to migrate up into the abdomen. And that migration process can get interrupted or can be confusing for the kidneys. And when that happens, we have renal ectopia. Now, there are 2 locations when we think of general renal ectopia that we want to check for an ectopic kidney. The first one is going to be pelvic kidney. This is the most common. It's also known as a sacral kidney. And what it means basically is that the kidney never left the pelvis during the migration period. And because of that then, it commonly gets mistaken for a pelvic mass. When people go to the doctor and they're kind of pushing around in their stomach, they can feel the kidney in that abnormal location, and then they get sent to ultrasound or CT to evaluate for the mass, and it ends up being that pelvic kidney. The other kind of interesting thing about pelvic kidneys is normally our kidneys get their blood supply from the aorta and drain into the IVC. Pelvic kidneys actually get their blood from the iliac arteries and then drain into the iliac veins. Now, the other area that we might see a renal ectopia occur is a thoracic kidney, and this is very, very rare. But what ends up happening is that kidney doesn't stop at the abdomen, it keeps going up into the thorax. Now, we as sonographers are going to have a really hard time diagnosing this because we can't see around the lung space to see a thoracic kidney. So we might expect that it's more agenesis versus renal ectopia. Here's another diagram showing the pelvic kidney. So again, the kidneys start in utero, down in the pelvis. We expect them to rise up into the abdomen during development. If the kidney fails to rise up, it's going to stay in the pelvis and it'll get its blood flow from the iliac artery and drain into the iliac vein. Now, because of location in the pelvis, the renal ectopic kidney is more likely to have stones, UPJ obstructions, which stands for uretropelvic junction obstruction. And so that's going to be an obstruction somewhere at the ureter and pelvic of the kidney being blocked, and they're more likely for a reflux, and that means urine coming back up the ureter into the kidney. On ultrasound then, we are going to see that the kidney fossa is absent. So again, anytime we see an empty fossa, we need to take a look around the abdomen. We need to look on the other side and look in the pelvis for that absent kidney. If we do find it down in the pelvis then, that is an abnormal position. Once we do find it down in the pelvis, they typically are mal-rotated. So instead of the medial portion of the kidney facing into the medial portion of the body, they tend to kind of flip on themselves. And so they aren't going to sit in the body the same way they would if they were up in the abdomen. And then lastly, we might see some of those complications being exhibited, being stones or fluid within the kidney. So here's an example of a pelvic kidney. We have the urinary bladder here, and then we have a kidney very close to it, not in its expected location. Moving on to our next anomaly, we have crossed renal ectopia. So now we're going to get into some more detailed versions of ectopia. Crossed renal ectopia being our first. This means that a kidney moved up into the abdomen, but then it went to the other side. And as the kidney moves to the other side, there actually are a couple ways that it can cause problems for itself. So we have crossed fused, which means that the kidneys migrate to the same side and then they connect to one another, where the kidneys are on the same side but are independent of one another. Now it's typical that the left kidney is going to move to the right side. So if you see two kidneys on the right side, that is most likely going to be a version of the crossed renal ectopia, and then you need to kind of figure out, is it non-fused or fused? The interesting part about crossed renal ectopia, though, is that both versions typically have a normal bladder insertion. So that means the ureter from the left kidney crosses all the way across the body to insert where we would expect it to, into the left side of the bladder. On ultrasound then, we are going to see a much larger kidney than normal, especially if they are crossed and fused. We would expect then to see an empty contralateral renal fossa. So that means if we see two kidneys on the right side, we probably aren't going to see a kidney on the left side. It might look like the two kidneys are attached, that would be fused, or it might look like two kidneys are just sitting next to one another, that would be the non-fused version. And we should still see two ureteral jets where we would expect them to be. So here's an example of fused crossed renal ectopia. We have one kidney here, and then we actually have a second kidney right here. It kind of curves down. So they are connected at the inferior pole of this one and the superior pole of this one. Another version of renal ectopia then is cake kidney. Now, cake kidneys, like I said, are another ectopia renal variant, and what cake kidneys do is they migrate up into the body, but instead of going to the sides like we expect them to, they head to the middle. And as they get towards the middle of the body, they are actually going to fuse together at the medial pole. And so when this happens, the kidneys do maintain their own collecting systems and bladder insertions, but now it looks like this giant, large kidney that sits right in the middle of the body. And the way that the kidney kind of fuses to itself, it actually does make it more likely to develop stones and pylokalactasis, which just means dilation of the collection system. So on ultrasound, again, we're going to see a large circular kidney at the midline. We might see fluid within the calyces, and we might be able to identify stones. Here's a diagram then of the cake kidney. So normally we have two separate kidneys here, but now we have a fused kidney at the medial portion of the kidneys. Here is an example then of a cake kidney on ultrasound and CT. So on ultrasound, it's going to look like a giant round kidney. We can actually kind of see one half of the kidney, second half of the kidney, and then they are fused through that medial portion. On CT then, we can see the kidney. So this is kidney 1, kidney 2, and they are fused together at that medial portion. As we had mentioned too, we can see that they each have their normal collecting system, the right extending through this hilum and the left extending through this hilum. Now our last anomaly is the horseshoe kidney. So horseshoe kidneys again are a variant of ectopia, and again the kidneys are migrating to the medial aspect of the body just like they do with cake kidney. But this time they're going to fuse together at the inferior pole. And when they fuse together at the inferior pole, they create a bridge of tissue, and we call that the isthmus. And that isthmus is going to be seen traveling anterior to the IVC and the aorta. On ultrasound then, what's going to happen is you're going to be scanning, and you're going to find that you've come a little bit more medially than you've expected that you would be. So normally we're off a little bit more lateral towards the body. You're going to end up being a little bit more medial than you expect. And then as you sweep down through that inferior pole, you're going to see it start to connect back over. So if you're really following the renal parenchyma in a horseshoe kidney, you should be churning with it, and you're going to see that you're going to connect back to that left kidney. So this actually makes them really difficult to elongate, just the way that they're sitting in there and the fact that those inferior poles end up joining together. So here's a diagram then of our horseshoe kidney. Again, we're going to have relatively normal looking kidneys, but their inferior poles are just going to keep extending and joining with one another at that midline portion. On ultrasound then, it's probably best seen in transverse at that inferior pole. We have the right kidney, the left kidney, and we can see the isthmus of renal tissue traveling between the two. That then sits anterior to the aorta. Here's another example. We have the right kidney, left kidney, and an isthmus or a bridge of pelvic tissue that connects the two on the inferior side. Again, that is anterior to the aorta. And that brings us to the end of our renal anomaly lecture. Part 2, we are going to look at evaluating renal masses.